Morning, good afternoon, and good evening, everyone. Thank you for joining us today for our today's Pathlife Forum called Siloed No More Leveraging TB Investments to Strengthen Primary Healthcare. I am Shibu Vijayan. I'm the Global TB Technical Director at PAP, and I'm delighted to be moderator for today's conversation. We'll start first by going over a few logistics. Uh, we very much want to hear from you during this conversation, so please share your question and comments with us, submitting them in the chat box or Q&A chat box at any point during the webinar. We'll have some time later half of this session for audience Q&A. In fact, I'd like to ask a question to all of our attendees today before the event's kickstart. Today's event is all about breaking down silos and leveraging existing proven interventions in TB to improve primary healthcare. Our speakers will share their thoughts on this topic. But I just want to ask you, share one way you think TB services can be leveraged to improve other health areas. Please type your answers in the chat box and send your answers to, we'll send all the answers to the panelists and the attendees. Thank you. And also please note, this call is being recorded and will be distributed to those unable to attend. So we received an overwhelming response in registrations. I see that we have participants joining from all parts of the world, government representatives, community organizations, NGOs, donors, as well as private partners. I also see that comments are actually popping up in the chat box, and very interesting comments are coming in. Yeah, so, and I also would want to note that TB control have been taken back by the COVID pandemic, and now Ukraine war has devastated health services, and TB is among the most affected in that region. Hope that the present crisis will end soon, and we all can support to rebuild that services. I also would want to send wishes to the health workers over there who are struggling to kind of restore the services over there. As an overview of our session today, I'll be briefly introducing our panelists, and then I'll turn it into Dr. Suanand Sahu, who is the Deputy Executive Director of Stop TB Partnership in Geneva. He's a strong advocate for innovation in care delivery, universal and equitable access, and people-focused work. Dr. Sahu will frame today's conversation, and then we will dive into facilitated questions with each of our panelists. We're also honored to be joined by an incredible group of activists, practitioners, and policymakers from Zambia, Democratic Republic of Congo, Kenya, and PATH's headquarters in Seattle. We have with us Dickie Settle, the Chief Digital Officer at PATH, Leah Shakala, a community mobilization specialist for PATH and Afia Misrea in Zambia. We have Mary Mamu, the HIV focal person for the Kambemba Health Zone Management Team at the Democratic Republic of Congo Ministry of Health. We have Maureen Murenga, the Executive Director for TB Women in Kenya. Huge thank you to all the panelists for joining us today. Now, I'd like to share a little bit about PATH's TB work. I know that you're all familiar with that, but for the past 2 decades, we have been working with global partners and high burden countries to overcome TB. Our work is driven by the knowledge that the TB is a leading cause of death among people with infectious diseases every year. It kills more women per year than all causes of maternal mortality, and is leading killer of people with HIV. All while resistance to TB drugs increasing and millions of individuals go undiagnosed annually. Due to the health care disruptions caused by COVID-19 in 2021, globally TB deaths has increased. You might have all noticed that. The pandemic has underscored the cross-cutting work for strengthening health system to make it more resilient as a whole is essential for the TB prevention and treatment. We are hosting today's session ahead of World TB Day, which is on March 24th, and I'm looking forward to the fantastic conversations about how advancement in TB care have proven to be beneficial in other health areas as they are being adapted to support people living with HIV and other infectious diseases. We look at how public health decision makers and practitioners have the opportunity to scale these developments further to strengthen the primary healthcare systems and integrate healthcare delivery to the patients first. Now, it's my pleasure to hand over it to Dr. Sahu for his opening remarks. Dr. Sahu, as I mentioned earlier, is a Deputy Director for Stop TB Partnership, Deputy Executive Director for the Stop TB Partnership. Sahu, over to you.
Thank you, Shibu. Good morning, good afternoon, or good evening to you all. First of all, greetings from the Stop TB Partnership, and I join Shibu in remembering the people in Ukraine, the health workers there, under this difficult situation in the conflict. We have a country there which belongs to the 30 high MDR TB burden country, and we are closely following up and helping from Stop TB Partnership in whatever way we can. Let me start by saying, as Shibu said, 24th March is World TB Day, and Stop TB Partnership develops themes for World TB Day to align partners in their actions. This year, the theme is Invest to End TB, Save Lives. We estimate in our new draft global plan that will be released in the middle of this year that at global level, funding for TB care and prevention, as well as research and development, needs to be quadrupled, 4 times quadrupled from current available amounts if you have to end TB. The return on investments on TB is impressive. Not making the money available will be more expensive. TB and airborne disease with drug-resistant variants could go out of control and pose a global health security risk. And addressing TB in the future will become more and more expensive. Now, let me talk about how TB investments can be leveraged beyond TB and benefit primary health care. We all saw the COVID pandemic, first of all, how unprepared the world was, but also how quickly tools were developed and scaled up against COVID. There are important lessons here for us to learn, and I would like to highlight 5 things as a recommendation on this topic of TB investments that can have benefits beyond TB. Number 1, TB programs we saw were launchpad for initial COVID responses in high TB burden countries. It was a natural choice, as TB programs had the expertise and the infrastructure to deal with respiratory infections. In early days of COVID, if you recall, early 2020, N95 mask was not a common parlance, was not known to people, but people in TB knew about it because it was being used. But what happened with this repurposing of TB programs is now well documented in terms of years of progress against TB that was wiped out. Now, why did this happen? Because TB programs had been chronically underfunded and did not have the surge capacity to deal with 2 diseases at the same time. So the first thing we must ensure, and this is my first recommendation, is that TB programs should be well resourced and should have the surge capacity. Second, we saw how TB diagnostic platforms were quickly repurposed to test COVID. COVID testing got scaled up in a few months to reach levels of scale which TB programs had never imagined that it will be possible in TB. Great lessons for TB on how to do large-scale testing with rapid turnaround of results, even so rapid as to allow people to catch flights. We have evidence to now suggest that multi-disease screening and testing is more cost efficient, and therefore, from Stop TB Partnership, our TB Reach facility will be announcing within the next few days a new call for proposal on multi-disease screening and testing. Stay tuned for this. So my second recommendation is multi-disease screening and testing at scale. I would encourage everybody to think about it. This is something that TB can contribute, and also other diseases can contribute to TB. The third point I wanted to make is contact investigation is an important tool to fight many infections, not just TB, but in TB also important. We saw how contact investigation was done in COVID. But in TB, it had never been prioritized by health system. TB has long history of doing contact investigation, but with many challenges. Many of you know about the challenges. It is now time to address those challenges and develop a contact investigation system for multiple diseases. So my third point is to think about setting up a system in the primary healthcare framework for contact investigation for not only TB, but learn lessons from TB, learn lessons from COVID, and also prepare the world for dealing with other infections using the tool of contact investigation and contact tracing. The fourth point I wanted to make is both COVID and TB can offer lessons to the health system on digital tools and live data and artificial intelligence and the whole area of digital health. Examples from TB include artificial intelligence used in X-ray, digital adherence technology, connected diagnostics. All these can be used and repurposed for other health issues and in the primary health care. So the fourth recommendation I'm making is to make digital health as the new norm, a new norm, not an exception. The fifth and the last one I wanted to make is, I want to talk about is airborne infection prevention and control. It has been a strategy in TB, but never prioritized by the health system prior to the COVID pandemic. We saw now how COVID has changed things, but people are still relying on masks. Mask is not the only answer. The TB world knows that there are many things beyond mask that can be done. So it is now an opportunity to equip the whole health system with airborne infection and prevention best practices, and to go beyond the health system also into the congregate indoor setting. So my fifth recommendation is to look at making airborne infection prevention and control universal across health system. Finally, I would like to say that investing on TB is investing in preparing the world against a future airborne pandemic. In preparing the world against a future airborne pandemic. Why I say this? TB is an airborne infection. Is there in all countries. If you look at the WHO report, all countries are reporting TB cases. And it is also likely to outlast COVID pandemic. If you think about a future pandemic that impacts humanity the way COVID did, very likely it is to be airborne infection. Therefore, it is important that the world invests on TB to be prepared for dealing with any future airborne pandemic that may happen. The world must invest on TB to build an airborne defense mechanism. Today, we have such systems for protection against missiles. Unfortunately, the world does not have good systems for protecting against airborne pathogens and infections. So I would stop there, and thank you for the opportunity.
So thank you so much, Dr. Sahu, for that opening remarks and framing, and also wonderful suggestions. So your 5 recommendations, at least I would say gold standard. To summarize what you just mentioned is like you mentioned about the surge capacity and surge investments requirement for tuberculosis. You also mentioned about the learnings from COVID about the multi-disease screening platform and rapid and mass testing. And also probably like we all need to raise our antenna and keep a watch on the next TB reach announcement, which is on multi-disease screening tools. And you mentioned about setting up systems of contact investigation within the primary healthcare setting, which will be a huge benefit for, I mean, not only for tuberculosis, other disease also, because we have seen that the importance of contact tracing, contact investigation during COVID days. And your fourth suggestion was on digital tools, and you did mention digital should be the norm, not as an exception or a nice to have thing. So that is where the few of our discussion points today will be kind of pivoted around digital only. And you did mention about the airborne infection control mostly in the health system, as well as it need to be universal, and also the emphasize its importance on indoor setting as well. So, and your closing remark is actually kind of spot on investing in TB is essentially prepping the world for future airborne infection. Thank you so much for that wonderful insights. And I know that you have other commitments today and you're in a busy schedule. So you are free to get relief from this conversation. We will keep you updated about the points evolving from the discussions today. And once again, thank you for your participation and your time dedicated for this important cause and discussion. Thank you. As colleagues, now we are actually moving to the panel discussion, which is the major part of this event today. So just a point to note that Mary will be answering the questions in French, and that the responses will be directly followed by an English translation by my colleague Ibu. So my first question is to Maureen. Maureen, I would like to begin with a question for you. Through your life, through your lived experience as a survivor of TB, you have the first-hand perspective on navigating a TB diagnosis in a primary healthcare system, which has led you to work and advocacy through the organization of TB Women. Based on this, what are some of the challenges that someone encounters when they receive a TB diagnosis? How may these challenges differ from women or adolescent case? Over to you, Maureen.
Thank you very much for your question. And I would like to first apologize if there'll be some background noise because there's some activity going on in the compound. And I want to say that I want to echo the words of Dr. Sahu. Integration would really, really help not only the public health space, but also help in the TB response. And we have a lot of lessons to learn from other newer epidemics such as COVID. We shouldn't be learning from COVID. COVID should be learning from TB response. But unfortunately, we are learning from COVID, especially let's begin with the basics like data. We could get daily COVID data, but we are really struggling to get some of the TB data. So the tools that are used to collect COVID data could be a good entry point. So I'll talk about multi-disease screening, what Dr. Sahu also mentioned. When in the early days of HIV, in the late 80s and early 90s, with HIV had a special place in the health facility, and it had a parallel clinic. So did TB, because TB was addressed in the chest clinic. And in the HIV clinic, we didn't have treatment. When I was diagnosed, there was no treatment. So people went quickly from what they were calling stage 1 to stage 2 of HIV to stage 3, and then finally stage 4. And stage 4 was what was commonly called AIDS. When I look back, I look at the symptoms people had during stage 4. It was thinning hair, darkening of the nails, diarrhea, persistent coughing, loss of weight. And this, if you look at it right now, this was TB. But because there was no multi-disease screening or integrated services, many people went undiagnosed. It was called AIDS, and people were left to die. Looking at it even further, you'd find that in my community, it's mostly the men who died first, and then their wives followed a year or two. And because we know how TB is spread, your guess is as good as mine, why the wives followed immediately. So that we lost an opportunity and we buried so many people. So how do you feel when you get a diagnosis, a TB diagnosis? First of all, in most cases where they don't offer point of care diagnosis, you have to leave your samples to go to the lab and come back for the results. When this happens, by the time you're coming for your results, the healthcare providers are already telling you to stand near the window. So there's already some form of stigma. And it is usually very scaring because TB has a lot of stigma and human rights violations. It gets even worse if you need to be isolated, because sometimes it's not done in a very friendly environment. There are people who are isolated and they are in very lonely rooms. And some women have to be separated from their children to be able to meet the separation. I mean, to be able to start treatment. So you find that when you first get the diagnosis, it is usually a mixture of confusion and a mixture of fear and self-stigma. And it is at that time that we always require adequate information about our health. It doesn't come in most public hospitals because of the numbers and stuff like that. So you leave the hospital very uncertain without adequate information on what you really need to do about your health regarding TB. There are people who are given probably a month's dose of medicine, and then they are told, make sure you take this medicine and complete it. And make sure when you're taking it, you eat food. So these are the people who will take the 1 month's dose of medicine, complete it, and feel better and stop taking medication. They're the same people who will not take medicine without food because they were told, make sure you have food when taking your medication. So it's a myriad of things that get into a person's mind. It is also sometimes leading to when you can't be able to go back to work, and sometimes you're the breadwinner, so you lose a livelihood, and without any extra support, it becomes very difficult. So the things that really come to my mind, that question was kind of tricky, but what mostly comes to our mind is the fear, the need for information, the need to get to know more about how our bodies will behave during this time we are having TB. We need issues around mental health, being a stigmatized disease, or let's say health condition. We need mental health support. And we also need treatment literacy and adherence counseling. I mean, guys, some of you are given vitamins or antibiotics for 5 days, and after 3 days, you can't remember that you're supposed to take drugs. So people who don't have shorter regimens of TB have to take them for a while. Treatment literacy, understanding the side effects and counseling is really, really important. And we lose a lot of opportunity because of many co-infections that happen with TB. When we get, for example, if you're HIV positive, there's a lot of myths and misconceptions that go around in relation to HIV, ARVs, and TB medication. So without that information, when our services are not integrated, then it becomes really, really difficult. Another challenge is sometimes when you are diagnosed or they screen you for TB and send you for diagnosis, if you're a person with another health condition, you are sent to a different clinic. Meeting the demands of both of them, especially if you're a young person or you depend on other people to support you to go to the facility becomes hard. So I have to go to one clinic if I'm a mother for the antenatal care. Then I go to another clinic for my ARVs, and then I go to another clinic for my TB treatment. So it becomes really complicated, and a TB diagnosis doesn't come. It's not an incentive. I mean, that's why you find that most of the time when we are coughing, when we are coughing or when you feel you have
intervening because we have other panelists also. Just wanted to kind of appreciate you sharing your story and also the suggestions. And again, with the key takeaway is that because you had a lot of cloud of confusion after actually getting diagnosis, and you emphasized on the importance of information to be provided to such a thing, and also testing, and then kind of getting it integrated into one place which is close to your residence or where we have access will probably demystify and destigmatize a lot of the challenges as a patient goes through. And very, very, very valid points. Now that we have Mary from the service delivery points from the public health system and the public, we know that Mary, that the Democratic Republic of Congo has made significant progress over the past decade to diagnose and link people living with HIV to treatment services, which include major improvements in strengthening diagnosis of tuberculosis and HIV co-infections. Are there strategies you have found that have been proven to be effective at overcoming some of the barriers of reaching and linking people with TB or TB-HIV to the services? Over to you, Mary.
Hello.
Yeah, I can hear you. Please go ahead. Ibu will have second.
Yes. I can speak French.
Allez-y, Marie.
Oui. En République démocratique du Congo, nous avons fait des grands progrès par rapport aux objectifs 395 et nous continuons à avoir des cas de diagnostic qui continuent à aggraver la double épidémie VIH et tuberculose, en particulier dans la province du Haut-Katanga et surtout dans la zone de santé de Kampemba, où l'épidémie est rampante parmi les populations très mobiles, telles que les mineurs et les transporteurs. Ces personnes ici échappent aux efforts actuels de dépistage du VIH, de la tuberculose. On inclut aussi celles qui ne se rendent pas dans les établissements de santé ou qui préfèrent accéder à des structures de santé qui ne font pas ces activités dans les zones où le système est desservi. Pour atteindre ces groupes qui continuent à ne pas se faire diagnostiquer, nous sommes associés à PAF par le biais du projet intégré VIH-Sida dans le Haut-Katanga, financé par l'USAID et les PNLT pour intégrer les services de dépistage du VIH dans les campagnes de dépistage de la tuberculose à domicile organisées dans les zones de santé à faible couverture sanitaire. Dans le cadre de cette stratégie, nous avons utilisé des relais communautaires ou RECO pour effectuer des tests de dépistage du VIH à domicile en utilisant soit des autotests, soit des tests rapides par prélèvement au doigt parmi les personnes présentant des signes présomptifs de tuberculose. Pour les personnes présentant des signes présomptifs de la tuberculose avec un test de dépistage réactif, les RECO les accompagnent vers les établissements de santé pour la confirmation du diagnostic de la tuberculose et ou du VIH avec référence des services de traitement ou de prévention. Nous avons observé un grand succès avec cette stratégie, avec une forte acceptation des services de dépistage du VIH parmi les personnes atteintes de tuberculose présumée et un taux de dépistage du VIH beaucoup plus élevé par rapport à ceux obtenus dans les établissements sanitaires et autres initiatives de dépistage communautaire, ce qui montre que cette stratégie était très acceptable pour nous, faisable et efficace pour atteindre et identifier les personnes atteintes de la tuberculose et du VIH dans les communautés.
Okay, merci, Marie. I will try to translate for the English-speaking participant about the point that Marie has made about the DRC and their fight against tuberculosis. In fact, in the Democratic Republic of Congo, while they have made stride against the 395 target, the country is still missing some cases that fall really the dual epidemic HIV and TB, specifically in the Okatanga region and specifically in the health zone of Kapemba, where the epidemic is driven really by highly mobile population of artisanal miners and also transportation providers. Individuals who continue to be missed from the current TB HIV really include those who prefer accessing health services at our other outlet and those in underserved area where there's more limited access to health facilities. To reach this group who continue to be missed, the PNLT, meaning the national program, partner with PATH through the USAID-funded integrated HIV/AIDS project in Okatanga to integrate HIV testing into existing household TB screening campaign held in area with limited access to healthcare services. And under this strategy, what the PNLT, meaning the TB program, national program, is using is healthcare workers, called in French relais communautaire ou RICO, to conduct HIV testing using HIV self-testing and rapid finger test among people who screen with presumptive sign of TB in their house. And for those who screen TB with symptoms suggestive of TB and or HIV, the RICO, meaning the healthcare worker, provide them with referral, accompanying referral to health facility for confirmation of TB and or HIV diagnosis with link to treatment or prevention services. And what they have observed in the DRC is that they had great success with this strategy, with strong acceptance of HIV screening services among people with presumptive TB and a much higher even HIV testing yield compared to yield that they receive in health facilities. And that community-based testing effort really is showing that this strategy was highly acceptable, feasible, and effective in reaching and finding people with dual infection, TB, and HIV. Thank you.
Thank you, Ibu, for that. Thank you, Ibu, for summarizing. It's essentially that empowering community and also integrating services for TB and HIV looks exciting, and also the yield you mentioned about also is impressive. So now, Dicky, you know that PATH Center for Digital and Data Excellence have made significant progress on digital adherence technologies, as well as advanced diagnostic technologies, including using artificial intelligence in X-ray scanning to detect TB. Now that we are also using cuff sound scanners to flag other lung ailments, can you share more about PATH's approach to comprehensive lung health and how AI is enabling these advancements?
Thank you very much, Shibu. Let's start with, as you mentioned, PATH's innovations in digital adherence technologies. As any of us who are on medication for chronic conditions know, myself included, people are not particularly good at taking medication consistently. People fail to take their needed meds, not through their own carelessness, but through unaddressed challenges, such as medication side effects. This is a ubiquitous human problem. In the US, a study of patients across 8 chronic diseases showed that 50% or fewer remained on their treatment after 1 year. Digital adherence technologies, or DATs, are used in many high-income settings to support elderly patients managing complex drug regimens, in drug trials where compliance is essential, and even for daily birth control.
PATH is working to bring these debts to more people in more countries and to support patients in more disease areas that are affected by non-adherence. As you've heard throughout the event so far, successful TB treatment is dependent on a daily course of medication. So much so that the standard of care has been directly observed therapy, requiring a patient to travel to a health facility every day to take their medicine, a frankly impossible ask for many in low-income countries. PATH has been proud to advance digital alternatives in several countries. For example, well before Ukraine took the world center stage in the current war, PATH has been working deeply in the country to address the endemic challenges of tuberculosis. In a recent 18-month pilot, PATH collaborated with health workers to deploy a smart pill box to 950 patients. These pill boxes have battery-powered sensors and a mobile data connection. When a patient opens the box, it alerts their healthcare worker. If the box is not opened every day, the healthcare worker can contact the patient to follow up. In this pilot study, 83% of patients took more than 95% of their planned doses, a promising step forward for TB adherence. Meanwhile, India is the highest TB burden in the world at 2.2 million annual cases. With PATH support, the country was the first to deploy digital adherence technologies at scale. PATH's conducted evaluations of multiple technologies in India since 2015, and have shown that a cafeteria approach, providing each patient with a choice of technologies, leads to more appropriate solutions tailored to individual context, demonstrating a true patient-centered approach. Ultimately, in both Ukraine and India, digital adherence technologies were able to identify challenges and provide more support where needed. Now, key to the success of digital adherence technologies is a low-tech approach to reach as many patients as possible. We're talking SMS, automated calls, basic tech that works for any phone. Let's now move to the other side of the technology spectrum. Shibu, you also mentioned PATH's work in improving X-ray diagnosis of tuberculosis. The familiar chest X-ray is a highly sensitive tool for early TB screening. The downside, however, is that interpretation of X-rays are highly subjective and are limited in their ability to confirm a patient has no disease. These issues are only compounded by the lack of qualified radiologists who can interpret chest X-rays in low-resource settings with a high burden of tuberculosis. WHO's recent guidelines on screening for tuberculosis recommend computer-aided detection, or CAD, software programs for interpreting digital chest X-rays in screening and triage for TB. Studies have found that using AI to interpret X-rays are an effective and suitable alternative to human readers, which is a huge advantage for countries seeking to increase TB diagnoses but lacking radiologists. At PATH, we're proud to collaborate with Cure.ai to test and demonstrate their QXR computer-aided diagnosis triaging tool, which raises the diagnostic accuracy of tuberculosis to greater than 95%. In Zambia, PATH deployed the mobile one-stop TB clinic in March of 2020. That clinic uses a digital X-ray with AI-augmented interpretation and a gene expert diagnostic reader. Together, these tools have helped diagnose more than 1,300 people. The same technologies can be used for more than TB. A computer-aided detection can classify common bone, heart, and lung abnormalities and ailments such as COVID-19 and lung cancer. Increasingly, the challenge of getting a patient to huge stationary X-ray machines is being overcome. Ultra-portable digital X-ray systems, small, wireless, and easily mobile, are helping us reach communities in hard-to-reach geographies. Even better, AI is enabling providers to begin making at least initial diagnoses without an X-ray at all. New technologies can evaluate the sound of a cough, offering a high-quality, efficient, and standardized approach to screening for respiratory issues, including COVID-19, as Dr. Sahu and Dr. Moringa mentioned earlier in this session. PATH is excited to be taking the lead in expanding the use of these technologies for a comprehensive approach to lung health in low and middle income countries, improving care for TB and going well beyond. Back to you, Shibu.
Thank you so much, Ashley. So I would want to recall again what Dr. Sahu mentioned about digital is the norm, not an exception. And again, you are coming up with a set of tools which can be probably deployed and accelerate the patient care cascade. Maybe if I'm coughing, I get a frequency which will probably flag me to an X-ray, which will read automatically. Then I get connected to a diagnosis, which is a rapid diagnosis as WHO approved, and then the connectivity solutions maybe help me, my doctor, in linking me to services. Is wonderful experience. Wonderful experience. Thank you so much for Dicky for bringing in and also summarizing nicely about all the work you are coordinating and also part is part of it. So over Leah, integration of care is one of the pillars of people-centric primary healthcare, and advances made in tuberculosis interventions are a perfect example of how we can leverage existing interventions to provide even better, more comprehensive care for patients. From your work on USAID-funded Eradicate TB in Zambia, can you share some examples of how you have applied strategies from the TB program to other diseases, disease areas at the community level, like HIV or COVID or any other disease? Over to you, Leah.
Thank you so much, Dr. Shivu, for that question. Community-based volunteers or community health workers have been pivotal in providing primary health care at community level and ensuring an enhanced patient care approach is achieved across various infectious diseases. In Zambia, over the past couple of years, we continue to see strategies from the TB program such as the direct observed therapy, contact tracing, treatment adherence, and support being extended to disease areas like HIV and COVID-19. In the TB program, they have adopted the DOT, the direct observed therapy strategy. This is where a community health worker provides support to a patient on ART to ensure that they take their prescribed medication by watching the patient take the medication to monitor response to treatment. So in the HIV program, the adherence support workers are trained to look out for signs and symptoms in the patient to ensure that they are responding well to treatment. Patient budding is actually equally another strategy that has been extended from the TB program to disease areas like HIV. This is where a community health worker is paired with a patient from the same community setting or religious setting to provide support to the patient to ensure that they remain in treatment and care. So in the HIV program, this is where you find a patient buddy being someone, a trusted family member, a close friend, or a community health worker to ensure that the patient stays on ART and they are able to monitor the response of the patient to treatment, as well as provide encouragement and support. Over the past couple of years, we also continue to see the contact tracing strategy being applied to disease areas like HIV. This is a strategy where a counselor in the HIV program is able to ask a newly diagnosed patient if they've got any people who could have been exposed to HIV through them. And of course, with consent from the patient, the listed contacts contacted by the counselor and they have been informed that they could have been exposed to HIV and they are offered voluntary testing. So this clearly you can see this is a strategy that has been a cornerstone of TB programs and has extended forth to programs like HIV. And 2020 and 2021 are clearly years that have been like no other with the coming of the COVID-19. We continue to see the extension of the contact tracing strategy to HIV, to the COVID-19 at community level. We saw the extension of this strategy to help in controlling the spread of the virus. At the peak of the pandemic, contact tracing helped in breaking the chains of transmission, as well as reducing COVID-19 related mortality through robust client identification at community level, as well as leading those patients into isolation, linking them into clinical care, as well as supported quarantine services. So clearly, TB programs the TB program has been a cornerstone of so many strategies being applied across these various disease areas. Thank you, Doc. Over to you.
Yeah, so thank you for that, because I mean, again, I would want to emphasize about what you mentioned about the patient buddies and also importance in investing in communities systems. And again, like if I recall what Dr. Sahu also mentioned, the importance of contact investigation and for large disease and EUCOP. I think there are a lot of learnings we need to learn from what Zambia team has done, and then especially your work on Leah, which will be a kind of I would say textbook for other countries to adopt and then integrate into more diseases. Thank you so much for sharing that experience. Now that actually we are moving to the round 2 of questions, like I appreciate every panelist to be precise and concise and restrict your answers to less than a minute. I'm going to Mary. Mary, as the government of Democratic Republic of Congo and major funders of HIV in DRC, such as PEPFAR, start to approach HIV programming with the goal of sustainable epidemic control, how do you see the role of integrated service delivery models, such as the household HIV and TB screening campaigns implemented in Hope Quintana, fitting in?
Allez-y, Marie.
Marie, over to you.
Merci pour la question. Et pouvez-vous la traduire en français?
Il disait que, bon, comme le gouvernement de la démocratique du Congo a fait des progrès signifiants, très importants, et que maintenant on parle de l'intégration de ces programmes-là pour un contrôle de l'épidémie qui soit maintenu. Comment voyez-vous le rôle des services intégrés, du modèle de services intégrés comme le dépistage à domicile de la tuberculose et du VIH comme implémenté dans le Haut-Katanga? Comment voyez-vous l'intégration de ce modèle-là dans le programme pour le maintien de l'épidémie, comment dirais-je, de contrôle de l'épidémie VIH, tuberculose en RDC?
Oui, pour ces modèles d'intégration, nous voyons que c'est bénéfique pour la RDC en général, pour le Haut-Katanga en particulier et pour la zone de santé de Kampemba, vu que de par cette intégration, nous organisons des campagnes de dépistage de la tuberculose et du VIH à domicile qui ont joué un rôle essentiel dans l'atteinte de nos objectifs de diagnostic des personnes d'accès difficile et atteintes de tuberculose et ou du VIH, et à les faire bénéficier des services de traitement, en particulier durant la période de la pandémie à COVID-19, quand les gens étaient très réticents à se rendre aux services sanitaires, les communautaires descendaient sur terrain pour les rechercher à domicile. Et deuxièmement, ça nous a permis de renforcer les soins de santé primaires centrés sur la personne, l'intégration du dépistage et des références pour plusieurs maladies, en particulier les comorbidités, co-infections, nous permet de nous fournir des services de santé plus complets qui répondent à tous les besoins d'un individu, ce qui se traduit par un meilleur traitement et résultat pour les personnes vivant avec le VIH ou à risque de contracter le VIH. Il y a aussi une importance de plus en plus croissante des modèles de prestation de services intégrés et décentralisés au niveau communautaire pour recevoir des services en dehors des établissements de santé et dans les communautés à la proximité des populations. Cela est dû du fait que l'essentiel de ces efforts, c'est pour trouver les cas non diagnostiqués de VIH et de la tuberculose et les orienter vers les services de traitement ou de prévention. En plus, dans le contexte de l'abandon de programmes verticaux, l'offre de plusieurs services à un seul endroit ou par l'interaction avec un prestataire est plus efficace du point de vue budgétaire, ce qui la rend finalement plus abordable et durable à long terme. C'est cela l'essentiel, d'autant plus chez nous en RDC, nous travaillons à la mise en place d'un système de soins de santé primaire plus efficace et plus durable qui nous permettrait de prévenir et de contrôler plusieurs maladies et nous menant ainsi vers le contrôle durable de l'épidémie du VIH.
Just for the some summaries for the English speaking. Basically, Mary was saying that this household HIV and TB screening campaign has been critical in helping them to meet the target for reaching people with TB and HIV who are hard to reach and remain undiagnosed, and getting them to really get treatment, particularly during COVID pandemic time, where people were very reluctant to really go to seek care in health facilities. But also using a person-centered primary health care approach, meaning integrating screening and referral of multiple disease, particularly disease that are comorbidities or co-infection with HIV and TB, enable them to really provide more comprehensive health services to address all the need of an individual, which really lead to a better treatment outcome, and also for both for people living with HIV and TB. And also what they realized that there is a growing importance of integrating and decentralizing community services to get service outside of the health facilities and into the communities, because once they start, putting this program, at a certain time there is a your results start being plateau, because there are some hard to reach people that you cannot reach, and you have to really do some community activities that can enable you to provide more comprehensive services to reach to those people who are not very well served, and those are critical for the last miles effort really to find missing HIV and TB cases and link them to preventive or treatment services. And also in the context of moving away from vertical disease specific silo, offering multiple services at one location, like one-stop shop or interaction with one provider, is more efficient from a financing perspective, ultimately making it more affordable and sustainable in the long term, rather than having a fragmented system, which is critical in the DRC, since DRC is working really to building a stronger and more sustainable healthcare, primary healthcare system that really will enable the country to prevent and control multiple disease, including HIV epidemic control. Over, Shibu.
Thank you, Ibu. It's actually exciting to hear that DRC is working towards a comprehensive primary healthcare program. So, Dicky, as digital health applications for the public health improve, how can we ensure that they are adopted at the primary healthcare and community level and accessible to all? Because if it is not accessible to all, then the whole talk about universal healthcare and equity will get compromised. What are your thoughts on that?
Thanks again, Shibu. You raise an enormously important question. Dr. Sahu addressed this, as you mentioned earlier, in his initial recommendations, asking that digital approaches become the norm, not the exception. And it needs to become the norm, not the exception, for all. With thoughtful planning and intention, we can ensure that digital technologies alleviate rather than exacerbate the pernicious health inequities that it is our mission here at PATH to resolve. In the absence of such careful consideration, however, we'll find we're adding the challenge of the digital divide to already overwhelming health equity issues. For example, limited cell phone ownership and access alone, even the most basic communication technology, is a major barrier to the adoption of the digital adherence technologies we discussed earlier. Thankfully, the global community has identified this challenge and is taking steps to recognize digital access as a critical new determinant of health. The recent Lancet Financial Times Governing Health Futures 2030 report makes exactly this case, that digital is a new determinant of health, and research is bearing this out. I was reading an article just yesterday where researchers at the University of Chicago found that one of the factors most consistently associated with a high risk of death from COVID-19 in the US was the lack of internet access. For every additional 1% of residents who had internet access in rural areas, 2.4 deaths per 100,000 people were prevented. In urban areas, the effect's even stronger. Every additional 1% of residents with access prevents 6 deaths per 100,000 people. That's with every 1% of access. It's truly fascinating that one of the largest impacts we might have on health going forward may not be a health intervention at all, but rather greater equity and access to these digital technologies. Also, new technologies like the AI applications we discussed earlier can be expensive, even in developed settings, which would be prohibitive in countries where they would bring so much value. The risk here is, of course, exacerbating again rather than alleviating health inequities. At PATH, we champion market strategies that help technology innovators price their technologies appropriately for the context, accelerating uptake and social impact of their products. Finally, we need to be mindful in change management approaches. Hesitancy and resistance with new and unfamiliar technologies is to be expected, and we need to implement these technologies with transparency and compassion. It's critical to share knowledge about these technologies with patients and health workers early and continuously. In this way, we can build demand and enthusiasm for these new technologies rather than resistance and distrust. So to sum up, equity and access to digital technologies at all levels, appropriate market pricing for the more advanced technologies, and building trust in new technologies through transparency and compassion give us 3 fundamental pillars we can all bring to bear in the digital transformation of global health. Back to you.
Thank you, Dikembe. As usual, you powered your arguments with the data and evidence and also the latest publications. Thank you so much for that exciting comments. So Leah, what will be the community-based volunteers need from donors, the private sector, the NGO partners in order to provide even more comprehensive health information and care to people where they are in the community settings? And what are your thoughts on that?
Well, that's a very interesting question. I think one of the key things that community-based volunteers, community health workers, you need right now is investment in capacity development. We need to see more support from the donor community, from NGOs, from our governments, by firstly developing a comprehensive, an integrated comprehensive training package which comprises of HIV and TB, COVID-19, nutrition, as well as family planning, because our community health workers are key in providing primary health care, and there is need for them to have an understanding of all these disease areas. Secondly, I would call for local resource mobilization through the private sector to support community TB work. In Zambia, we have done so much as eradicate TB, but we would love to see more financial support for sustainability to support TB, community TB work, as well as other programs as well. So I feel those are 2 key fundamental areas we would really love support from the donor community in line with community-based volunteers.
Thank you for that, emphasizing the importance of further investments. Maureen, we started with you, and also we would want to sum up with you. And what does a comprehensive package of care look like for someone affected with TB?
So for someone affected by TB, the first thing we need is information on the nature of diagnosis, whether it is latent or active TB, whether it is MDR, extrapulmonary, so that they're able to really understand the kind of TB they are dealing with. And then we need treatment literacy and adherence counseling, so that they're able to understand the side effects of the treatment they are taking, and also be able to adhere well and stay on treatment the full. Social and mental and nutritional support that really is key to ensure that their health and well-being is taken care of. Where possible, we need shorter, less toxic treatment regimen, digitalized health systems, and point of care diagnosis. Thank you.
Yeah, so you summed up it really, really well, Maureen. That was actually spot on. I just wanted to re-emphasize on what we heard today. We heard about innovations in TB service delivery through community systems, digital advancements, importance of integrated care, importance of counseling and further patient linkages, mental health, addressing the stigma. Now it's time to leverage these innovations for optimizing primary health care. I would want to reiterate the World TB Day message this time: invest to end TB. That will save life. Every $1 invested in TB is actually returned as $43. So thank you so much, all the participants and panelists, for attending this discussion. It is a wonderful discussion. There is a lot of actually questions coming in. We will certainly get back to you. And the recording of this session also will be available for the participants who are registered. And I will continue to be for integrated care, as we have seen. A lot of thoughts came in, and also would want to emphasize, re-emphasize the digital advancements and the investments in digital health. Thank you so much. Bye.
Thank you.
Merci Marie pour votre participation. Merci des efforts.
Merci.